I'd like to thank the organizers for giving me this opportunity to look at this complex various presentations and give my own views on the same. So fine-tuning therapy in HER2 early breast cancer is now the need of the hour, and the reason being that you have very good outcomes as evidenced by the long-term results from the pivotal trials, the increasing therapeutic options, and then knowing the toxicities. So you would want to personalize therapy in this situation, and as seen over here, you're either escalating therapy with longer durations or adding new agents or de-escalating therapy with subtraction of chemotherapy or having chemotherapy-free combinations. So why is this needed? Because the risk of recurrence on current treatment to de-escalate therapy, low risk to reduce the toxicity. So you have to have strategies in place to risk stratify. So what are the current traditional parameters that one depends on? So these are the clinico-pathological characteristics that you are very well aware of, most important being the residual disease post-NACT, and in future and even now as it is developing, integration of clinical and genomic variables. So gene expression profiling and genomic tests. So this is the background, and I quickly move on to the why this is needed. So, the clinico-pathological characteristics cannot capture the heterogeneity that has become obvious from this PAM50 study of the clinically HER2 positive patients. As you can see, they mirror what is seen in the HER2 negative population, and HER2 enriched is only 47% and the others are distributed as shown here. And on the right side, you see the various pathways which are in play, not only involving the tumor cells, but also the microenvironment. So quickly coming to the first is the new HER2-DX assay for predicting pathological response. How is it different from the others? It is a 27 gene which have been identified, and they look at various modules, that is the immune inhibition, the luminal differentiation, and then of course you have the HER2 enriched. So you have various 4 signatures, and incorporated with that is the clinical data. This is how the gene test was actually developed with a training set, and you can see the various trials. I won't go into details because of shortage of time. So you have various data sets of patients in various studies as well as from the clinic, which have been used for training, validation, and this has then been explored in independent data sets like the TCGA, the Metabric, the ScanB, and the CalGB 40601. And you have 3 scores. One is the HER2-DX risk score, then the HER2-DX PCR likelihood score, and the ERB2 messenger RNA assay. Now the last one is also gaining importance because you need to better define the low HER2 patient population where you have got now therapies coming up. So now, what is the association between the HER2-DX variables and the PCR and survival? As you can see on the left-hand side, the blue, which is the immune signature, and the luminal, you can see that as far as these blue are concerned, their survival is much better than the red, which is the proliferation signature, and also depending upon the tumor stage and nodal stage. On the right-hand side, you have the PCR likelihood score, and again you can see the blue do have a better PCR rate, and these are mainly the immune signature, the HER2 enriched, and the proliferation signature. Whereas as expected, the luminals have a poorer pathologic complete response rate, which we are very much aware of. So it's quite a bit reflecting what we actually have already seen. Now if you look at this score, HER2-DX score, it is prognostic, and you can see those with a low risk have a better survival than those with a high risk, and this is significant. If you look at the HER2-DX pathologic complete response likelihood score, then the patients are stratified based on whether they have a low chance of achieving a PCR, a medium, or a high chance as shown on the right-hand side. Then you come to the third aspect of this assay, and which is the ERB2 messenger RNA assay, and again the patients are then split according to the cutoff into the HER2 negative, that is the ERB2 low and ERB2 high. And you can see that some which are HER2 negative, you may get actually a positive ERB2 messenger RNA assay. So again, one of the features is whether we can better define the HER2 low population. In conclusion, this integration of clinical and genomic data has been clinically validated, as I mentioned in the first slide, in different data sets and could be used to escalate and de-escalate therapy. So what are the downside to it? The integration of this data, however, is from 3 different sources with different median follow-ups, and we need prospective data as you have with the Oncotype DX and the MIND-ACT studies to actually put these into clinical practice. They are complementary, and there may need to be developed an algorithm how you use these. The take-home message is promising, but prospective data needed for clinical use, not ready for prime time. How do we use this HER2 genomic test in the PEARL-LISA trial? As you know, the PEARL-LISA trial was looking at the response to letrozole for 2 weeks, and then those who had a molecular response with a Ki-67 reduction of more than 20% received letrozole along with the dual HER2 blockade with pertuzumab and trastuzumab with no chemotherapy. Whereas the non-responders, weekly paclitaxel was added. So the aim of the study was very surprisingly to evaluate the ability of HER2-DEX assay to predict 2-week letrozole response. As you know, this assay is actually designed to predict the response to anti-HER2 therapy and to evaluate the ability of this assay to predict PCR in patients on the non-chemotherapy, that means the Herceptin, pertuzumab and letrozole arm. And as you can see, these ROC curves are important. The more that the AUC is close to 1, those are significant. So if you see that when it comes to prediction of 2-week, it's the HER2-DX PCR score which is important, and it has an inverse correlationship. That means if you have a high score, then there is an endocrine resistance and the response to 2 weeks of letrozole is actually less. So if you look at this, it is inversely correlated to sensitivity. So a higher PCR score, it actually is equal to an endocrine resistance. Then what about prediction of PCR after a non-chemotherapy related dual anti-HER2 therapy with hormonal therapy? Here you find that the HER2-DX PCR score and the ERB2 assay, these are the two which correlate with the prediction of PCR on this arm. So higher the scores, better is the PCR. So these are the two scores which correlate with the PCR. So in conclusion, we can say that triple positive HER2-DX PCR score is associated with actually endocrine resistance, and the other two scores as mentioned with the PCR. It does not help us to evaluate the assay to select patients who should not receive chemotherapy along with the dual HER2 therapy. However, optimal candidates for this would fall within the ERB2 high group, where there is a 53% PCR, and it could be considered for incorporation into future trials. What is important is it needs validation in prospective trials. The HER2-DEX was actually designed to test sensitivity to anti-HER2 therapy and not endocrine therapy, as was the first aim of this study. And how does it perform in the paclitaxel arm? We don't know about that, and the long-term data is important. Coming to the development of a prognostic gene expression signature, again for the early HER2 positive, they took the patients from the Neo Alto study And again, they had undergone the gene expression profiling at 2 times, and then these were compared, and you can see that the PCR rates were higher in the letrozole and combination of letrozole and the trastuzumab arm, but the EFS was similar in both. So you had a S18 gene signature and a reduced 5 gene signature, and both these were associated with event-free survival. And the conclusions from this study were that these were actually stratified patients with different prognosis. Prognostic value of both was independent of clinical and pathological variables. So that is an important point to remember. And it confirmed that other gene expression platforms, it was validated. The clinical confirmation was performed in the adjuvant study setting, but further studies are needed. So you can say that it's a low risk. The point to be raised is this low risk signature which has been, can it identify patients, and can this be clinically useful information? We don't know. Does this provide additional independent information as opposed to the immune related signatures or the HER2-DX assay? So you see that every study is bringing out a different set of genes, but the signatures are important, that the immune signature, the HER2-ended signature, they are better, they can better predict the pathologic complete response and are associated with survival. And luminal signatures, although they do not predict for the CR, have improved survival. Now this is the prognostic and predictive implications of the intrinsic subtypes in the pooled analysis of these 3 neoadjuvant studies. And these are the 3 neoadjuvant studies, and the RNA sequencing was done on 781 patients. And you can see that as expected, that the association of PCR with EFS is extremely strong in the HER2 enriched and the HER2 basal, as seen in the above 2 graphs. And if you look at the EFS benefit, then this is mainly restricted to the HER2 enriched. To some extent with the basal, but not so with the HER2, the luminal subtypes. And this is according to the expectations. If you look at the PCR predictors, then again you see at the top, the blue line, it's the immune activated signature which is important. Whereas if you look at the EFS predictors, then you find that again it's the immune activated signatures and HER2 enriched which are important on the right hand side. What is seen in the red box is very important, that there is MAP kinase signaling, and this may be used as a target to overcome the negative impact of this pathway in these patients. So in conclusion, one is that the benefit of dual versus single HER2 blockade is limited to the HER2 enriched. Immune signatures are highest PCR and EFS, and as mentioned before, the luminal signatures have the lowest PCR but good survival. Overexpression of the MAP kinase pathway could be a target for further studies. Now coming to the I-SPY 2 trial, and as you know, this is an adaptive study where to the backbone of trastuzumab and paclitaxel you add different interventions and see the benefit of these interventions. So this is the, by doing the gene expression profiling, one could see the responsive predictive subtypes, and as you can see that the PCR was higher in the HER2 positive basal group, and the HER2 liminal group it was reduced. All agents except the AKT inhibitor, this is a new AKT inhibitor, showed greater efficacy in the HER2 enriched group. But what is important is this particular inhibitor showed a benefit for the luminal group. So in fact, it is felt that in the luminal HER2 positive group, it is the endocrine pathway which is more important than the HER2 pathway. Now, what is the identification and biologically driven HER2 positive in the ALTO trial? As you know, this was a negative adjuvant study where there was no benefit for the addition of lapatinib in the adjuvant setting. And as you can see, it was the trastuzumab alone arm was taken, and the patients, it was a case control cohort study. So the patients selected were either those who had relapsed on trastuzumab or those who were disease-free. And at 2 points of time, the gene expression profiling was done, and the PAM50 intrinsic subtypes were also incorporated. And you can see that there are 5 subgroups here. And again, they actually overlap with the previous subgroups that I have mentioned. And you can see, again, the immune activated do much better. And of course, the luminal also, as you can see on the right-hand side, the red curve and the blue curve right at the top is the immune activated and the luminal. The HER2 enriched, which is the pink curve, is in between, and the proliferation and the mesenchymal subgroups do badly. So this also tells us from this large data set which immune signatures do better than the others. So my take home on genomic classifiers is that is there an Oncotype DX on the cards? Well, the need is there, but we know that we have so many classifiers, and there are large genomic data sets as mentioned in the presentations in the neoadjuvant, the adjuvant setting, some integrated with clinical data, but they need prospective randomized clinical trials like the TAILOR-X and the RX responder to be used in clinical practice. Now coming to the last two is the FERGAIN is assisting the potential of metabolic imaging to identify candidates for chemotherapy de-escalation in the HER2 positive population. So you look at the arm B, where you have only the dual blockade along with endocrine therapy, and then after about 2 weeks, 2 cycles, the PET scan is done. And if the patient has a responder, and I'll tell you what is the cutoff for the response on FDG PET, then you can see that they're continued on the same arm without chemotherapy. But if there is no response, that means there is less than the cutoff, then the chemotherapy is added. So what is important here is the cutoff that was used in FDG PET, and there are various statistical methods, training and validation used to actually come to that cutoff, and that is 40%. 40% reduction in the FDG value as compared to the baseline FDG PET is the cutoff for a response. And you can see that the PET responders on the B arm with only hormonal therapy and dual blockade is 79%, and the PCR in responders is 37.8%. So you are achieving a path complete response without chemotherapy of 37.8%, which is definitely inferior to actually the inclusion of chemo. So characteristics of the PET responders is mentioned here, and the median SUV changes in responders is about 69.6%, and in the PAT CR it is around 77%, and which is significant. Now they tried to increase the cutoff value for the change in SUV to 77%, and what they found was then the PAT CR rate is of those without chemotherapy is almost equal to the same as with chemotherapy. But then you would be offering chemotherapy to more number of patients. With a cutoff for 40%, 30% could avoid chemotherapy in the whole treatment plan. The values of PCR and PET-based pathological response adapted strategy should be confirmed because we are waiting for the final IDFS survival data. This is very important. This study is very important because it was multicentric, multinational study. Now coming to the last, that what is the mechanism of action of trastuzumab deruxtecan? We all know that, so let me quickly move on to the study. It was the use of this drug in 3 cohorts. The top cohort is the one which is truly positive. The other cohort is where it is +2, but ISH or IHC +1 and FISH negative. And the last cohort is totally HER2 0. And you can see on the right hand side, the best objective response rate was seen with, of course, cohort 1 as expected. In cohort 2, it was 37.5%, that is the HER2 low, as you know. But what is interesting is those who had 0 also, showed a response rate of 30%. Of course, the PFS also fell in line with what is the response rates as seen on the left-hand side. Now, what is the objectives and sample connection techniques? For want of time, I won't go into the details, but as you can see that at various time points, the tumor biopsies were done and the blood sample also collected initially. And the techniques we used were immunohistochemical mainly, but also whole exome sequencing. The take-home message is that TDXD anti-tumor activity was associated with levels of HER2 expression, and the distribution of the HER2 expression level showed a moderate correlation. There was a decrease in the PDL1 expression was observed on treatment with TDXD, and a high percentage of HER2 zero cells, especially at the periphery of the tumor, was associated with non-response to Durexican. A decrease of HER2 expression was observed in 65% of patients who progressed on Durexican. So HER2 expression is a key determinant of the anti-tumor activity, as we know. So with this, I would just like to say that these genomic classifiers and the knowledge of this gene expression profiling is bridging the gap between the molecular heterogeneity and putting it into clinical practice. With this, I come to the end of all the presentations. Thank you.